Mixed cannulae, expanding performance standards. High-performance cannulae for direct and femoral cannulation in minimally invasive cardiac surgery. LivaNova's complete range of mixed dedicated products allow easy and reproducible procedures. The portfolio includes the sutureless aortic valve Perceval, Memo 4D for mitral valve repair, the HeartLink system for assisting the perfusionist in applying goal-directed perfusion therapy, and a broad choice of high-performance dedicated cannulae. LivaNova's range of cannulae suit every cannulation technique for minimally invasive cardiac surgery. Venous and arterial femoral cannulation can be performed using the WRAP venous cannula and the EasyFlow Duo. For arterial direct and venous femoral cannulation, the EasyFlow aortic cannula and the WRAP are available. For venous femoral access, the LivaNova WRAP cannula features a dual-stage configuration for optimal drainage of the inferior and superior vena cava without interfering with the right atrium. The high-flow dynamics of WRAP improves the capability of drainage with a low pressure drop. An optional Sellinger dilator kit is available to perform percutaneous insertion. The LivaNova EasyFlow Duo cannula is designed for a safe and smooth femoral arterial cannulation. Its conical dispersion tip design allows a more gentle flow in the femoral artery, and its red cap avoids blood backflow during obturator removal. A dilator kit for percutaneous insertion is also included with the cannula. EasyFlow cannulae are designed for safe, reproducible, direct aortic cannulation and include a malleable stylet to aid cannulation insertion, facilitating bloodless introduction into the aortic arch, as well as a special conical dispersion tip for a more gentle flow in the vessel to reduce shear stress.
The point-of-care program at Huntsville Hospital is approaching its 20-year anniversary. As we began to grow as a hospital and provide more complex services to our community, the need for point-of-care testing became very clear in our organization. Many of our departments consider the EPOC device to be crucial to their ability to quickly move their patients from entry to the hospital to procedural room. It helps them monitor the patient's status during their procedures and post-procedure, so it's very integrated into our entire continuum of patient care. If you have any patient population where blood management is crucial, then a point-of-care device is very useful in those types of settings. It can provide a quick result on a very small amount of blood, and that is really important in some of our patient population.
We are starting a new process where we're going to screen our patients on the floor for sepsis. The patient can look and actually feel okay. They will show us signs and symptoms of sepsis. So what we do when they show these signs, we get a lactate level.
Lactic acid is a product of the sepsis cascade. So with sepsis, the inflammatory light switch goes on, the cascade starts churning, and unfortunately, once it starts going, we have to stop it. It will not stop on its own. The faster the lab draw, the faster the lab results, the faster you can act on it.
The process in the lab is what the process is. It just takes a certain amount of time for the instruments to run those tests.
I mean, we're talking 30 minutes even on a stat because that's the process. That's just how long it takes. There's not really anything you can do about that. For every hour you wait to give an antibiotic, the mortality for that patient increases 8%. So now that we have the handheld device, the nurse can get those results within a few minutes, and we know how to treat that patient. If a patient is going into septic shock, we do not have minutes to spare. We have got to get it done quickly. So when you get the little beep from the EPOC that says your results are in, you go with it. You don't even think twice about it. You're like, this is good. This is what I'm going to do for this patient. The next steps are clear.
I think our mortality on the initial floors dropped by almost 50% in the first 3 to 6 months. At this point, we're about hospital-wide. I think we'll be hospital-wide another 2 to 4 months. So this has become a huge program within our system.
Without the EPOC device, it would really be hard for us to get everything done in the timely manner. So it's really helped us to get our program going.
I mean, whether you're a surgeon, whether you're a medicine doctor, whether you're a dermatologist, you want to be able to do things in a timely fashion so that you can be most effective.
This really makes a difference in patient outcomes.
Like all perfusion professionals today, we are busy and frequently short-staffed. Does taking time off for a conference create a burden for your teammates? Has reimbursement for your continuing education dropped? Have you priced the cost of going to a meeting lately? Registration fees, airfare, transportation and parking, hotel, and meals out? This totals up to having an out-of-pocket expense of over $2,500. And then you hope the content is good. Perfusion Education has heard your concerns. They have a simple and seamless system that works on any platform, computer, tablet, or even your phone. You can chat during the program or even phone in and be live on the air. The content, second to none. Perfusion Education is by perfusionists and for perfusionists. Create a free account and check us out today.
Hey, everybody. Hey, welcome. Good morning, everybody. Okay, so you can tell we're here at a different time of the day. We're trying to accommodate all the various different time frames now around the globe, which is a great problem to have. So we're switching times up a little bit for our European colleagues and partners, and also for, I guess in the evening time, it'd be pretty late in the Southeast Asia sections. But nevertheless, welcome this morning. I want to take just a moment and thank our sponsors, if I may, LivaNova and Siemens. And we're going to be adding, very excited about this, a third and fourth sponsor coming up very soon. But I've got to thank these two. LivaNova and Siemens were there from day one, and without them, we could have never, ever achieved everything that we've been able to achieve. So I want to thank them very much. Our social media platforms, make sure you go there. You can like, follow, share us on Facebook, on the Twitter, on the LinkedIn, on the YouTube. Make sure you click the subscribe button and also click the little bell so that you get the bell icon notifications and you can be notified whenever we're going to be going live. It makes it a little easier for you if you can't remember the schedule that, hey, they're live now. And you can just listen to the program, watch the program, obviously, on your mobile device. So you can watch us on any platform. You can have a computer, you can have your TV, if it has internet connection, obviously, YouTube. You can watch it on your iPad, you can watch it on your cell phone, whatever you might want to do. Also, check out our websites, please. We have perfweb.us, and just so you understand, perfweb.us is really a scheduling site for upcoming events. Perfusioneducation.com is the actual member site, and membership, of course, is free. And within that perfusioneducation.com is where you become a member, but you're able to then either become an unlimited CEU earning member, which does have a cost associated with it. Watching these programs is free across the board, and we always want to do that. That's philosophically where we're at. We want it to be free. We believe in the sharing of information. Where any conferences that we do are going to end up the same exact way, which they're going to be free to participate, to attend. You only pay if you need the CEU certificates. And the other thing then is also, so I did I just lost my train of thought. What was I saying? Oh yeah, no, not join the faculty. No, the programming. So you can become a member unlimited. You can do the Canadian bundle. You can do individual sort of cafeteria type where you pick whatever you want, buffet style, and pay for them. And then you have a system where all your certificates are kept. You can take the exam, evaluation, you can get your certificate, the whole thing. It makes reporting for the boards a whole lot easier to do. So that's the difference between PerfWeb and Perfusion Education. I highly recommend you just check both out and look at them. If you have any questions, you're always welcome to email me, and you can always email us and contact us at, of course, contact@perfusioneducation.com. If you'd like to perhaps join our faculty, you have a topic that you really like, you want to do something that you'd like our programming to do, you can send us suggestions there or just reach out and say, hey, I really want to join your faculty. We're going to skip the call-in number today because we are doing, let's go ahead and bring Tammy up. We're doing something. Good morning, Tammy. How are you?
I'm good. How are you?
I'm doing great. Okay, so we're doing something really different, I think. And this was Tammy's idea. It's a brilliant idea. I really loved it. So we're doing this is the inaugural Tammy Sparacino's Journal Club. However, it's going to be a little bit different than a traditional journal club in that we're not really going to be critiquing the journal article. We're going to be using contemporary articles that are about topics of things that we as clinicians, as perfusionists especially, are concerned about. And then we're going to look at the articles, kind of look at what they did, but look at it from a how does this relate to what we do, sort of a lecture / discussion, but also using how they measured, how they performed this particular study, the why they did it, the method that they did it, and, you know, not critiquing the article, but more looking at, for example, using NIRS during cardiac surgery. I think we all have a lot of experience in it, but we're going to be bringing data in from other places as well. So I also want to make sure that you know that we're not opening the phone lines because John Ingram is going to be on the phone. In fact, he should be on the phone with us now. He's traveling. All of us, whether it be Tammy, whether it be me, whether it be John, we're blowing it up as far as being busy is concerned. This is a challenge for us to get the program up, operational, running, on time, on schedule, but we're committed to it and are going to continue to do it. And I think today's program, in fact, I think this new Tammy Sparacino's Journal Club is going to be a tremendous hit, and it's going to be very, very successful. So I'm very happy about it. And then John, of course, as I said, is on the phone. We all know John Ingram. We all know Tammy. I'm going to skip most of the introductions, and I'm going to turn it over to Tammy right now and let you take it. So take it away, Tams.
Okay. David, if we could bring up the slides, please. Okay. So today we are going to be looking at this article that was published in March of this year in the Journal of Clinical Medicine, and its title is The Association Between Cerebral Oxygen Saturation with Outcome in Cardiac Surgery Using the Brain as an Index Organ. It was written by Young, G, Joe, and Associates, and we're going to go ahead and just get to it.
And it was published when, Tam?
March 19th, 2020.
In the Journal of Clinical Medicine. Got it.
Oh,
Okay.
yes. Published in the Journal of Clinical Medicine. Correct.
Got it.
All right. Next slide, please. Okay. So I'm going to just briefly go over the abstract. The abstract reads, while both baseline regional cerebral oximetry saturation, which will be abbreviated RSO2, and interoperative RSO2 decreases have prognostic importance in cardiac surgery, evidence is limited in patients who received interventions to correct RSO2 decreases. The primary aim was to examine the association between RSO2 values both the baseline and intraoperative decreases in RSO2 with the composite of morbidity endpoints. We retrospectively analyzed 356 cardiac surgical patients having continuously recorded data of intraoperative RSO2 values. Per institutional guidelines, patients received interventions to restore the RSO2 value to equal to or greater than 80% of the baseline value. Analyzed RSO2 variables included baseline value and the area under the threshold below an absolute value of 50%, which will be abbreviated AUT50. The association with outcome was analyzed with multivariable logistic regression. AUT50 was shown to be an independent risk factor along with age, chronic kidney disease, and cardiopulmonary bypass time of adverse outcomes. In cardiac surgical patients who received interventions to correct the decreases in RSO2, increased severity of intraoperative decrease in RSO2 as reflected by AUT below an absolute value of 50% was associated with the composite of adverse outcomes implicating the importance of cerebral oximetry to monitor the brain as an index organ. Next slide, David. Okay, so first let's talk about, I kind of broke up how we're going to talk about this article. Joe mentioned that we're not really critiquing their methods. We're more using it as subject matter, current subject matter for us to discuss and be able to decide if this is something that is applicable to our practice, if we think it's useful, and going from there. So the first thing I want to talk about is the why. Why did they want to write this article? What's the problem that they saw? Basically, the significance of why this study was done. So they state that the reason, the why they did this is that although it's known that baseline regional cerebral oximetry decreases or low baseline regional cerebral oximetry values are important in cardiac surgery, there's very limited evidence for patients who received interventions to correct these. So what they did is they're going to look at all of these things and try to be a little more specific in what they are looking for. They state that many studies have been done already, but the results are conflicting, and it's hard to use these different types of results or insignificant values that they receive and apply it to everyday practice. Their goal, or their what, if you will, go ahead, next slide, David. Their problem that they wanted to solve is they had two aims. Their primary aim was to examine the association in RSO2 between baseline and intraoperative decreases with the composite of morbidity endpoints. They also had a secondary aim, or their sub-goal, which is to evaluate the variables that were associated with RSO2 value that showed significant association with adverse outcomes. Okay, next slide, David. All right, next is the how. How did they do this? Well, they did a retrospective study analysis at their hospital, which is Severance Cardiac Hospital in Korea, and they looked at a little over 1,000 cardiac surgeries, and they then eliminated anything that was off pump, that used circulatory arrest, that was an emergency, that had previous history of cerebrovascular disease that required any kind of intervention, any cerebral vascular events that had happened within 1 month, acute coronary syndrome, or recent MI. So that left them with 356 valvular surgeries. So those are the only ones that they're going to analyze. Now, the device that they used was the Invos Cerebral Somatic Oximetry 5100. It's manufactured by Covidian.
That's the
and it uses NIRS technology. I think we're all pretty familiar with, just generally speaking, about this. And they qualified their patients by baseline had to be taken on room air before anesthesia, and then had to be continuously monitored until they transported to ICU. All right, and let's see. They looked at records from March 2017 until April 2018. And what the endpoint morbidities that they looked at were taken from the STS database registry. They included permanent stroke, renal failure, that was defined as a serum creatinine increase of greater than 4, or 3 times the most recent preoperative creatinine level, and that anyone who required new dialysis. They also looked at prolonged ventilation greater than 24 hours, deep sternal wound infection, any cause of reoperation in the absence of an evident surgical bleed. And then they also looked at, for their secondary aim, they looked at the factors of hemodynamic and ABG variables, temperature, hemoglobin, and and they compared those to either a low baseline RSO2 or a significant decrease in intraoperative RSO2, depending on their association with these adverse outcomes. Okay, next slide, please. Okay, so now we're just going to go ahead and get to the author's results and conclusions. The authors found that out of their 356 patients, 47 of them had morbidity endpoints. Of those 47, permanent stroke occurred in 5 patients, which was 1.4%. A reoperation occurred in 7 patients, or 1.9%. Renal failure in 8 patients, 2.2%. Mechanical ventilation greater than 24 hours in 29 patients, which is 8.1%. Deep sternal wound infection in 4 patients, 1.1%. And a mortality in 1 patient, 0.3%. An important result they also came to was patients who exhibited a composite morbidity endpoints had higher incidence of preoperative CKD, higher incidence of heart failure. They had a higher Euro score, which is similar to our STS score of risk evaluation, and lower left ventricular ejection fraction, lower hemoglobin, lower albumin levels, higher creatinine levels, and longer CPB time than ones that didn't have those morbidities. All right, let's go ahead and discuss their conclusions. Next slide, please. Okay, so this is their conclusion. In conclusion, cardiac surgical patients who received interventions according to the cerebral oximetry monitoring increased severity of intraoperative decrease in RSO2 as reflected by AUT below an absolute value of 50% was found to be an independent risk factor of dismal prognosis, implicating an important ancillary role of cerebral oximetry to monitor the brain as an index. All right, next slide. All right, let's go ahead and open this up to discussion with our panel with John and Joe. So what did you guys think about this article?
John?
Can we hear John?
Is John there? Do you have yourself muted, John?
Can you guys hear me?
Yes, we can now.
Hi, John.
Okay, yeah, I'm in an airport and I'm dealing with multiple headphones here, so hopefully you guys can hear me okay.
Yeah, we can hear you
Anyway,
fine.
That was great. You okay?
Yes, we can hear you fine. Go ahead.
Okay, so Joe, I wanted to point out something here that I found fascinating about this. Going back to some of our other presentations that I think Tammy and you and I have all been involved in, with fluid overload on patients, use of hemoconcentration, use of albumin. If you look at the results on where it says, let's see here, it says under preoperative laboratory values, these people that had in the morbidity category had a necessarily lower albumin level. They had a lower urine output, and they had a much higher total infused fluid volume. And if you think about the things that we talked about in our previous presentations, it's interesting that when we talked about overload of fluid with patients having its own morbidity, allowing patients to be overly third-spaced, and in particular, not giving enough albumin and keeping the osmotic pressure up. And all of this ties in with the use of the hemoconcentration, or lack thereof. And this paper, if you look at the values and the morbidity category, all highlight the same effect that we were talking about in some of our other webinars.
Yeah, I agree 100%. I was wondering, Tammy, can I ask you to do me a favor?
Sure.
Can you please go back in your data and give me again the percentages on the endpoints that were measured, the morbidity endpoints?
Sure. Okay, so there were 47 out of 356 that were found to have morbidity endpoints. First category was permanent stroke. It occurred in 5 patients, which is 1.4%. Next category was reoperation, 7 patients, 1.9%. Renal failure, which was our highest category. Well, actually, that's not true. Mechanical ventilation. But renal failure was the second highest category with 8 patients, 2.2%. Mechanical ventilation greater than 24 hours in 29 patients, 8.1%. Deep sternal wound infections in 4 patients, 1.1%. And mortality in 1 patient, 0.3%.
Thank you. And John, I agree with you 100%. I think that, this is a. I thought the article was a good article on its own merits, but I think that it was very narrowly focused, and I was a little, frankly, put off, if you don't mind my saying so, by the fact that they left off all of the off-pump cases, because that would have been an incredible amount of data that would have been acquired. How many times does the heart get picked up, the head gets turned, or whatever's happening to obstruct the drainage out of the brain? And then, of course, on the on-pump cases, they really didn't clearly, I think, illustrate what the perfusion technique itself was. How did they ultrafiltrate? What was their fluid balance when it was all over? I know they said that they transfused on pump at, I think it was 7, and off pump, I thought it was 8, if I remember correctly, somewhere around there. That was their transfusion threshold, which is really, I think, somewhat liberal. But of course, I believe in higher hemoglobins, especially the sicker the patients. But I wanted to compare those endpoints for the on-pump cases anyway, the stroke, the renal failure in particular, and the prolonged ventilation. I was surprised their deep sternal wound infections were that high. Mortality seems, I guess for that thing, for valves, I think, valves tend to be a little bit more, let's say aortic valves, they tend to do real well, but I don't know how many were aortic, how many were mitral. I don't think the article even said that. So,
it doesn't state.
Yeah. So, there's a lot of interesting data in here, but a lot that's lacking. John, what's your thoughts on all of that I just said?
Yeah, I know we didn't really want to focus on criticizing the article, but I think people need to know that when they only selected valve patients and didn't do any CABG patients, I'm not sure why they did that, but those patients alone are going to manifest a higher cerebral and an embolic complication rate. So I think that kind of fuzzies the water here a little bit, because you're looking at the brain as an end organ indicator for perfusion, but you're using the highest risk brain injury patients that we have, maybe other than circ arrest patients. So I thought that was a little perplexing. But when you look at the article overall, you do get some pretty, there's some meat on the bone in the sense that there's some benefit to monitoring, and I think people need to at least take this part home with them. There's some benefit to monitoring the cerebral oximetry on your cases, and there's some benefit for sure for addressing it when it gets to be lower than what your baseline was. I think there's some benefit there for sure, and it will, I think, adjust how you do your perfusion if you do this on your cases. And one other comment is, I didn't see on there, when you talk about their perfusion parameters, what did they do with the level of the PCO2 on pump? Mm-hmm. It talks about the end tidal, being 40, but they're talking about anesthesia when you're off pump there. I think.
Well, no, I think
talk about.
John, I'm sorry. I think what they did was, forgive me, I think they measured the end tidal coming out of the oxygenator vent. So there is you can. If you do it correctly, if it works well, it is a good surrogate for PCO2.
So when I ever had monitored NIRS on pump, it will cause you to run higher CO2 levels. As you guys know, it'll cause you to run CO2s in your high 40s, because this is a pretty powerful influence on increasing your numbers on your NIRS reading. And I don't know how well they did that, but this is a retrospective paper where they didn't have control over what the papers in the studies they were reviewing did, right?
Right.
So they didn't have control over that. But one of the take-home messages is too, I think, for people listening, is you should, if you're doing the NIRS on your cases, you'll find that you're going to want to run higher CO2s, or actually you're going to have to, because your numbers will suffer overall if you don't, on not every patient, but on a lot of your patients, you'll find that you'll have to run higher CO2s, and then you'll like it, because you'll see that your NIRS numbers go up without having to greatly increase your blood product usage, for example. The other thing they talk about is increasing their flow from 2.0 index to 2.5, but I guess they never went above 2.5 and trying to increase their numbers when they were not very good. Mm-hmm. So, you're really limited by the surgeon being flooded when it comes to increasing your flow. That's really your mm-hmm. bigger limitation, or maybe high line pressures. But they seem to stop at 2.5 and then start addressing some of the other things like blood pressure. I was glad to see that the articles didn't use a lot of neosynephrine. They used other vasoconstrictors, but they didn't use neosynephrine, which I was kind of glad about that, because I think that would have skewed some of these numbers when you start using neo too much, mm-hmm. for your regional perfusion.
Mm-hmm. Yeah,
what are your guys' thoughts about that?
I think so. I think you're seeing more people switching to levoteranol now, or Levophed. I think, or Norepi, whatever you want to call it. I think that's becoming more and more mainstream, moving away from neosynephrine at this point in time. At least that's what I'm seeing. Tammy, what about you in your practice? Does everywhere you go, and you probably go to, I think, 8 hospitals, do they all use some form of NIRS, cerebral oximetry?
No, actually, I don't think they do. But in my previous practice, we did, and we used it. We charted it, and we had key points in the case when we were writing down those values, and then the monitor, if you were in an on-pump case, was angled in such a way that it's no longer under anesthesia's area, and it was aimed for the perfusionist to be able to do interventions. And when we first started using it, and we had the sales reps and clinical reps come out from the companies of the one that we were using, of course we talked about increasing flow to increase your numbers. But again, like John said, you have to balance that between flooding the patient, flooding the surgeon, which if you're in a valve, of course, you can help out a little bit with your vent. But if you're just in a cabbage on pump, you don't have as much control of that. Something else that we used as an intervention was increasing your gas sedation on pump. Now, you have to already have a good mean arterial pressure for that, but we did notice that with a slight increase, even 0.5 increase on patients that were having trending down with their cerebral oximetry, that you could see a positive result from that.
That's interesting. Yeah, that's a pretty small change. But you're saying that small change.
Of course, it depends on the patient, but you start out with that, and a slow increase in that would, on many patients, rise their numbers. And then even if you're flowing a 2.2 standard kind of flow for your patient, even going up to 2.4 could show a major increase, is what I found.
Well, yeah, and I think that that as far as the flow is concerned and flooding the field and all of that kind of thing, I mean, I think at the end of the day, we're limited by the size of our cannulas. So you can overflow your return, and of course, that's going to cause its own problems. You're going to not only have the heart filling up potentially, unless it's open, but you're also going to have your venous pressures going up, and potentially have a post-capillary obstruction to flow, and it all kind of works against each other, making the situation worse and worse and worse. So, we are limited by the size of our drainage cannula, and then we're limited by the size of our return cannula and how much afterload we can pump against. Most arterial cannulas are, plus or minus, I guess, the size of maybe my index finger, and the aorta, is usually about, that big. So there's a rather big difference between the size of the cannula versus the size of a native artery that is your main artery feeding out of your heart and your body. So that's, I think, an issue. I'd like to go over, if I could, can we throw a slide up, and let me just show you this.
Real quick before we move on, Joe, if I could just bring up this one point. It was in their discussion kind of towards the end that I thought was interesting, because how I had always used this in my practice was, charting your baseline, charting your values when you went on pump, charting with cross clamp, charting when you start warming, charting when your cross clamp comes off, and then charting just as you're coming off pump. So those were the main values. Now, I continuously charted, so with every chart entry I had one, but those were my key points that I had to make sure that I had. And the device we used was a trend model, and so of course you're just comparing to whatever your baseline was, assuming your baseline was taken at the appropriate times for anesthesia and oxygen and all of that. But what they determined, this particular study had a focus on what if your baseline is poor? What if you're already starting out at a deficit? And so using, most, I think they said the manufacturer recommends that anything that would be a 20% decrease needs an intervention. However, if your baseline is already low, let's say you're already at, 60, 70%, a 20% decrease could be below what they thought was a safe level of the AUT of 50% absolute value. So I thought that was interesting, because if you're starting out with a poor baseline, you can't really use your trending model correctly in that respect. You really have to see if I can do an intervention to be able to raise their starting values. You can't change the value that they came in with, but if you could do an intervention immediately to try to raise those values, so that then you have something closer to your absolute threshold, then it seemed like that was going to be a better way, a better practice to be using, because a lot of times we are getting these really sick patients and they don't have a lot of functional reserve to be able to really dip down below the recommended absolute value.
Mm-hmm. Mm-hmm. Yes, and I think that makes a lot of sense. I think there are two different concepts, and I think that I hear what you're saying completely. Of course, this particular device that they used, and we can talk about the various different technologies that are out there, and I think that's going to be another very important, interesting part of this discussion lecture period today. But the baseline is done, as you had said, prior to oxygen administration, sedation, anything. And so if you have a patient who is perhaps, a little sicker than most, maybe they're not an emergency, they are elective, but they're in heart failure, maybe they have some underlying pulmonary problem, and they're already a little hypoxic, plus they're in heart failure, they may be fluid overloaded because of that. So you have that as a perfusion derangement that it's causing a perfusion derangement. So your baseline may be it may be appropriate and accurate for the patient in this setting, but not necessarily if that patient had been tuned up, so to speak,
right,
in the hospital for a longer period of time, had their heart failure more aggressively treated, maybe with diuretic therapy or dobutamine, or whatever it may be. Maybe they just need a little bit of supplemental oxygen. So is the baseline even a valid thing to have for any patient other than that which would be what we would consider an otherwise healthy, truly elective operation? I think that's the issue for me.
That's the point. Yeah, exactly. Because we were using on every patient, and of course, most of your patients are going to be your standard patients, elective cases, but there are some that aren't your truly, sick, just the standard sick, and their baselines are likely going to be lower, and so you really, if you're going to use the cerebral oximetry numbers, you need to consider that you're not waiting for, interventions from their baseline. If they're starting out with, 40, then you're probably need to make, as soon as you're on pump, you need to start making interventions to see what you can do to get that number up.
Mm-hmm. Probably just going on pump is going to fix that. But
yeah.
I also, want to address, and John, I want to drag you in here real quick. I'm sorry, but I also want to address the issue of the difference between regional saturation or the, they call it the watershed area and so forth. The difficulty in actually measuring that and what it really means and how these technologies work, the accuracy of them, the dependability of them, a lot of other variables that I think we have to consider. But it's very different than actually measuring flow in the brain. So, for example, TCD. And that's a little bit further, I think, in this lecture, but I just wanted to throw it out there that we're looking at regional saturation through the skin, through tissue, through the bone, through a mixture, a network of vessels, which are both venous and arterial. It's not specific to the arterial saturation of the brain, obviously. And so I think that there's a lot of technological challenges that go with this. I'm curious, John, how often do you see the use of this? Are you seeing it in the use of ECMO? Another important question I had for you, because I know you see a tremendous amount of ECMO, more so than we do, and I think we see a lot. And do you see times when people see the number is not what you want it to be, but they ignore it for whatever reason? We don't believe it, there's nothing else we can do, whatever the situation may be. What's your thoughts on that?
Yeah, several comments. First of all, sorry, there's an announcement going on. But the article actually mentions, here, it says 70% of the measured oxygen saturation comes from hemoglobin of the venous bed. We're talking about the probe itself, what it's sensing. So what you said is kind of a mix of arterial and venous, but it's actually 70% of it's venous of what it's indicating, and therefore you're kind of looking at the O2 extraction rate when you're looking at a NIRS monitor. So that kind of is an interesting thing. And it also states in here that the FDA recommends that this monitor be used largely as a trending device, right, which all of us kind of knew, but it actually says that in the article as well. So there's a little bit of a fuzzy on what you're doing with the numbers, because they're not giving total validity to the number. They're giving a lot of validity to the change that goes on once you put this device on. And you guys can hear me? You guys can hear me? Okay. So in regard to how much I'm seeing it, let me answer that in two ways. On bypass, I don't think even half the people are using it routinely on bypass, because this is anecdotal, my experience. I would say that it's somewhat under half of the people are putting it on every case in the OR. And in ECMO, it's far lower than that. It's way down there, about, probably 10% of the people I see doing it, and maybe not even that much. So I really hard to answer your question as to whether or not they're treating it or ignoring it. I try to encourage people to put it on all ECMOs, but I'm not finding a whole lot of success. Because if you'll put it on ECMOs, both on the cerebral and then on a couple of your limbs, you'll see regional perfusion differences, especially in your femoral cannulated people, where the perfusion is lax in that limb. You know what I mean?
Yes. Yeah, I was wondering. In fact, I was going to ask you. I was going to ask you if you're seeing it being used in the periphery as well, because I've seen that where, especially when you're femorally arterial cannulated, you'll see it down on the calf.
I think the ideal thing is to have at least one or two probes on the forehead, one on the right arm, and one on a lower limb. If you'll do that on all of your ECMOs, you will learn to be a better ECMO perfusionist, and your clinical site will learn to be a better ECMO clinical site, because you will see north-south syndrome on your right arm versus the limb. You'll see poor limb perfusion. You'll see poor regional brain perfusion for different postures that you put the patient in, for different blood pressures, for different flow rates on the ECMO, and you'll be like, wow, we really are having regional changes here and regional effects with what we're doing with this patient. If you give more vasoconstriction, you might see some things different. So there's so much going on. As you know, they're on so many drips, these patients, and then we're tweaking the ECMO machine, and then we're turning the patients. So, go ahead.
Yeah, that sometimes. I just was making a comment. Are you guys proning a lot of your patients now on ECMO?
We're seeing a lot more of it now, even pre-ECMO. Starting to see a lot more of it other places that I've been. I see a lot of patients now laying on their stomach, pre-ECMO especially. And then on ECMO, not too much. I have seen it. It's so difficult for most centers. I don't think your new centers are doing that. I think a certain amount of your more experienced centers are diving into proning, and because it's challenging and scary for people who've never done it. But it is emerging more and more as a general rule. I'm seeing it a lot more. I think with the COVID thing, people are willing to try things, and proning is definitely one of those things that people are trying a lot more often for sure.
Well, I can tell you, and Tammy, I'd like your opinion about this too. The patients that I have seen on ECMO, especially those that had the VV ECMO, I'm specifically talking about VV ECMO here, especially with a single cannula. But if you're on VV ECMO, but you have a big time cardiac output, and your cardiac output is, double, really, almost, or the same as what our ECMO flow is. We're flowing 5 liters on the ECMO, and their cardiac output's 8, 9, or 10. We certainly do see that reflected in our in our arterial circulation, in our regular patient blood gas, with little lower saturations because of the mixing. And when we prone those patients, I'm seeing a huge difference. That's been my experience, again, anecdotally, not done by any study, but those patients that we have proned on ECMO that were running a SAT of 93, 94, flip them over and it's 97, 98. I've seen it go as high as 100. I've seen pretty remarkable changes. Tammy, are you seeing that also?
Yes. And John, we are, particularly at one of our institutions, all of them seem to be proning a lot more now with COVID. But at one of our institutions, they are very interested in proning these patients, of course, to hopefully prevent ECMO. But then once we're on ECMO, it's one of the first things that we are trying to get done. Even if they don't have the bed available to do it, we're manually proning. And I agree with Joe. We are seeing a huge improvement, and in fact, so that the patients look incredible after proning, especially maybe 1 or 2 times. They're proning, I think, somewhere around 16 hours and then flipping them back supine, and then the next day kind of repeating the process. And we've seen some incredible improvements with that.
I will say this. I think, and I'm not a strong advocate of using cerebral oximetry, not because I don't think it's a good idea. Mine has more to do with what I'm concerned about, the reliability of the tool. And I can discuss that maybe as we move a little forward in this presentation. But I do feel that it would be a better tool for us to use, in particular, because we're seeing so much VV ECMO. I probably don't mean in particular the VV, but I'll say it for this and then maybe revise it later. But I think having that is a better tool than using an index finger pulse oximeter, because again, John's point, the pressors and other, just their own physiologic changes in peripheral vasoconstriction to shunt oxygenated blood where they want it to the brain and the other important organs, you're going to see I think you would see very big differences in your numbers looking at cerebral oximetry versus pulse ox. Or more reliable, because I think the arm can be compressed. You could have peripheral vasoconstriction. You could have you could have the catheter in there causing some distal perfusion deficit, and I just don't find that pulse ox is as good a tool as this would be, a cerebral oximeter would be, for monitoring these high acuity patients who are really needing to make sure that we keep their oxygen levels as high as possible.
I think that would be a very interesting data collection to do if we were able to monitor the pulse ox while they're on these VV ECMOs and cerebral oximetry numbers over the whole ECMO run, because these runs are tending to be a little bit longer. So, we having about 2 weeks worth of data. I think that would be really interesting information.
I think it would be too. And I think it would also be a little bit better for us to fine-tune our ECMO sweep gas and find the optimal PCO2 level for any individual patient.
Agreed. Yeah, because John, are you finding a lot of your people, hospitalists or intensivists, whoever's managing these VV ECMOs specifically, I'm speaking about COVID since that seems to be kind of on everyone's mind right now. If they're running these higher CO2 levels, like even more so than usual, we're seeing that they're accepting, rather than like 50, 55, some of them are even accepting, up to 60 PCO2 levels, and they're fine with that. What do you think about that? Have you seen that?
I think that's become a trend. Yeah, I think it's become a trend where your people are becoming to accept PO2s even in the 50s easily, and then CO2s in the 50s and 60s, and sometimes even higher. And I don't think they're doing it because it increases cerebral perfusion, because most of them aren't putting a NIRS on there to see that. They're accepting it because they don't have a choice. The oxygenation and the ventilation is so poor, even with the ECMO cranked on max, we're pretty much stuck unless you start doing some radical things. And that's what I was going to say about the proning. The proning works great when it works, and there's times when, for whatever reason, it doesn't work at all. But one thing that people should always think about with any of these patients, not just COVID, is your VQ mismatch in the lungs. Is people are laying on their back, right? They're laying on their back for days and weeks at a time. So the blood is pooling in the posterior aspect of the lungs, right? And when you prone, and plus also proning does two things. It drastically changes your VQ mismatch, which is why you said a minute ago, Joe, you suddenly prone them and you see your SaO2 go up 5 or 10 points, right, or something like that. It also moves the secretions around. So it does two things. It helps mobilize the secretions, and it helps change your VQ mismatch. And that's very important. Both of those things are very important, especially now that we're struggling so much with COVID patients.
Absolutely,
but it really
John.
works on a lot of ARDS situations. It works very well. I have seen it when it didn't work, and I think those are when you wait way too long to try it. If you wait way too long to try the proning, you might find that, this really doesn't work. Why are we doing this? If you have somebody on ECMO for 45 days and you start trying proning, your damage is probably long since done with the lungs, and you may not make much difference when you start to prone. But proning is now done very early on, sometimes right away in the ER when they walk in and they're having difficulty breathing. And then, so earlier on is better with the proning, and it does have a huge impact with an awful lot of patients. Not everyone, though. That's the interesting thing.
Dr. Samir is actually recommending people who are feeling like they may be, they may have a COVID exposure, feeling like they may have a little bit of shortness of breath, but not bad. Highly recommending those people sleep on their stomachs. And so, I mean, I think that a lot of people are recognizing that I guess these lesions tend to or infiltrates, whatever they are, that's causing this problem is developing more in the posterior lateral aspect of the lungs. You're laying on your back, you got gravity, you got the blood running that direction on your VQ mismatch that you're talking about, and flow preferentially going that direction. You flip over, and if your anterior lungs, the anterior section of your lungs are clear, then you're going to have, or clearer, you're going to have a better ventilation and oxygenation opportunity there. So I think that's part of it. I wanted to talk to you, though. You just brought something up, John. I know we're changing the topic just a little bit, but I think this is very important. I don't have a problem with a PCO2 of 60 at all. That doesn't bother me one bit. Having a PO2 in the 50s, frankly, that bothers me a lot. I understand, if you were to use, Tammy, your, and that's a PO2 in the 50s, understanding that's going to be a little bit, much higher saturation. Probably what would that be, 90, 92, 93%, 91%, somewhere around there. But if you were to use cerebral oximetry on this, I would guarantee you, I'm not positive, but I'd be willing to bet that you would be below that absolute value of 50%. And so for me, what makes people heal is oxygen. Oxygen is needed. And all of the goal-directed therapy articles that have been written, I think, are very clear. I think the data is conclusive that supranormal DO2, since we're talking about oxygen delivery of oxygen, is very beneficial to outcomes. So I would say if you can't achieve a PO2 greater than 50 on your arterial circulation while you're doing ECMO, you need either more cannulas or you need a second ECMO circuit. But the whole idea is oxygenation. That's the whole point.
I mean, that's the point of ECMO, correct? We're trying to help with oxygenation and, of course, CO2. But I agree with you, Joe. I think those numbers are incredibly low, and I know that some of it is just everything's maxed out already, and maybe people don't feel comfortable or haven't considered adding additional cannulas or another ECMO circuit with another oxygenator.
Yes. Well, I don't think there's any doubt that, this is a good article to stimulate a lot of discussion about a lot of things. Can we, do you mind if I move forward with some other slides? So let's throw another slide up there if we can. So stroke. Okay, so we were talking about one of your endpoints being permanent stroke, but of course permanent stroke is the kind of stroke that we see when it's fairly obvious. They're drooping on one side, their faces droop, they can't eat soup because it spills out of their mouth. A stroke is a stroke when we think about it, but there's a lot of other types of neurologic sequelae that occur secondary to some neurologic event, which could have been hypoperfusion, could be embolic, we don't know, okay, in cardiac surgery. But so the point of measuring, I think, is important. We can talk about, again, the debate regarding the accuracy and dependability of cerebral oximetry, but it is what we've got. Other than TCD, which I think would be superior to look at flow, and perhaps that's inferior because it doesn't actually measure what that flow is. The flow could all be deoxygenated blood. It will still measure flow. So I understand everything has its limitations. But perioperative stroke rates in cardiac surgery range from 1.7 to 2.9%. This is by the, this is from the actually STS database. But with that said, their stroke rate, their permanent stroke rate, you said was 1.4%, which is consistent with what we see. It's pretty low, it's low, but in valves, it's usually much, much higher. It's certainly closer to that 2.9%. And again, this is a real stroke, not an encephalopathic type of stroke, where you have the subtle changes and delayed extubation. Those are very high, 7.7 to 13.8%. And at the end of the day, you could take the slide down. That really, that very much correlates with, or is it highly influences the cost, not only of the patient's, quality of life, but the cost of delivering the care. So when you look at those kinds of numbers, you think to yourself, when the hospitals, because they do say, do we really need to spend this much money for this device? Is it really beneficial? What's the data? Or where do you see that it says this should be a standard of care? It's not a standard of care by any means, but should it be? Do we need validation studies? Do we need to make these companies make these tools, where they are reliable enough and consistent enough that we can actually say this is a standard of care? Because I do think we should be monitoring the brain. We're perfusionists. What are we supposed to be doing here? We're not just supposed to be making a still dry field for the surgeon to operate. We also have to keep the patient alive so that they remember who they are and their family is at the end of the procedure. And that usually comes from the brain. John? Tammy?
Yeah, I'm here. That's why I'm such an advocate on using the NIRS. It may not be perfect. There's probably better devices that are going to come out in the future, but it's what we have at the moment, right? It's what we have. And we can try and certainly make the best of it and try to make, and the more you use something, the more you inherently get to know and get a feel for what the device is telling you. So you know, it's not perfect, but it gives us some pretty good trending. If you put it on correctly and you use it every day, you'll begin to rely on it and see that you can make some changes. And Joe, I wanted to go back and say one thing. I wonder what it would look like if you had the nears on a forehead and a right arm and a lower limb, and then you proned the patient. How that would change.
It would be very
interesting too. I agree.
It would be, absolutely. It would be. I think that there's so much opportunity to be doing so much research that could validate this. But you know, we're constantly battling. You know, what these companies will invest in from an R&D perspective. You know, they want to make money. Which is understandable. It's a business. I don't have a problem with that. But, you know, at the same time, you know, what does their investment truly need to be? You know, let's throw up a couple of slides. I want to go over some concepts here. And I think these are very important concepts for people to understand when you talk about NIRS. The concept is easy, but making them work in a usable device is really hard. And one of the big problems is how each device figures out the saturation information coming from the skin, subcutaneous tissue, muscle, bone, and brain. And that would be also venous versus arterial blood. As you said, 70% is venous that we know of, and I'm sure that may have some dependence on where the device is placed, how it's placed, and what the anatomical considerations are, where the little laser lights are, or the infrared lights rather, are shooting in, how many lights and sensors does any one probe have. There's probably a lot of variability that can influence that. Anyway, go ahead back to the slides. Each device uses a different approach for delivering light and analyzing the light reflected back. Each device uses a different approach to compensate for absorption by the different tissues. The analysis algorithm for every device is different from every other device. No two commercial oximeters measure the same thing. The specific algorithm used for most devices is kept secret by them, and the companies keep changing the algorithm so that a study you do in 2005 may no longer be applicable in 2013 or 2013 and 2020, as the case may be. No device is capable of providing a pure brain saturation value, no matter what they say, and the signal from all devices is, as I said earlier, contaminated by extracerebral blood. And here is a very quick example. I've used this slide before. It's an important slide. If you put this on a living patient, and it doesn't matter which device it is, you will get a range and a mean. So this living patient's about 68. If you take and kill the patient, you will have a mean of around 50, then you see the range. But if we not only kill you, but we remove your brain, then you will still have a mean of around 72. And when you see studies like this, it gives you, and this isn't the only example, there was the other article, pumpkin or patient, and there's been other things since then. It gives you pause to really consider, if the numbers are great on the cerebral oximetry, I want to know I can believe it. If they're bad, I want to know I can believe that too. Okay, you can take the slides off, thanks. So that's my take on this, John, and that's one of the biggest concerns that I have, is truly knowing whether, again, TCD isn't perfect because it's not measuring saturation. It's also a lot more complicated to do. You can put TCD on, you can prone the patient, you're going to have to re-aim it, and it's flow, not oxygenation. We need to know we can trust these numbers so that when we see them good, we're comfortable. Hey, we're doing something good here. When we see them bad, hey, we really need to intervene. And when we see them go from bad to good, they really went to bad to good and what is good enough, and feel comfortable about what our intervention may or may not have been. That's my biggest issue with this. And Tammy and I had a conversation with somebody yesterday, and that person told us, and they're very involved in NIRS and cerebral oximetry. They told us that the Somnetics is the worst device because it does not give you an absolute value. It's only a trending device. However, when you go back and really explore all of these devices, every single one that claims they are an absolute measurement device are lying, plain and simple, because they cannot do that. It can't happen. So, John, I'm going to turn that over to you.
Yeah, we actually had a bunch of brand new ones that we bought. I think it's the Insight, if I'm not mistaken.
Invos.
I want to say.
Invos?
Well, no, it's.
Insight.
No, I think there's a newer one.
It's by Terumo, I think.
Okay.
Does that sound right?
I don't know.
Yeah,
Something like that. And I was reading the brochure, and the brochure indicates that the beam of light shoots down into the very superficial edges of the brain. And I was like, never read an article where it says that. You know, that's the company talking. It's really very difficult to get beyond the scalp, right, and the blood flow to the scalp. And then, you know, they're talking about the watershed area where you're sort of getting to the important tissue of the brain, but I think it's very patient dependent, physician dependent. Probably matters how much body BMI the patient has, and just a whole myriad of things, you know, to where and what you're really reading. So if you get a baseline and the probes stay where they are, they don't get moved during the case, hopefully, you can use that as at least something that's telling you, am I keeping it at that level, or is it getting worse or better? And the actual number, you know, you'll just know that's what you started with before you went on pump.
Mm-hmm.
You know, basically, I think is the best we can do. It's kind of like, it's not like a blind person walking around, but it's a person with good sight, but they're walking through a very dark room. You know, you can sort of see, but you're not really sure that you're seeing everything, you know what I mean? And you could kick into something.
Mm-hmm.
So we was kind of like that with these devices. You know, you're getting a vague picture of what's going on, but it's certainly not a very definite and inconsistent from, you know, patient to patient and whoever puts the probes on, and maybe even a lot of other things like hemodilution, those things that are probably throwing it off.
Well, and even something as simple as sweat. You get a sweaty forehead, you get a bad reading. They slide off, and then you once they start doing that, you can't get them back on. But I think, Joe, your point is valid. I mean, these aren't numbers. You know, these aren't real measurable numbers. But I do agree with John that they provide a little bit of information. I mean, that's what we do when we're on pump, is we use all these devices to give us clues. Mm-hmm. You know, we use similar for, you know, venous saturation. We use that for flow. All of those things aren't exact, and maybe those have been around a little longer and the technology's improved and we can trust them a little bit more. They have ways to calibrate the venous saturation, but it's still not perfect. But I'm not looking at my venous saturation in a way that I'm going to say, oh, you know, it's 69. I got to do something. I don't want to be below 70. I'm looking at it as, what changes have I made? What would cause that to, you know, drop? Is there any intervention I can do to raise that up? I'm not looking at it as an absolute number. And I think that's the same way with the types of devices that are available right now, is we need to look at them as, am I going in the wrong direction? Mm-hmm. Whether they say they're absolute or not, I don't think that's important. I think you take that information, and if no changes have been made, you on your pump, they're not doing anything different at the field. You feel like you have proper sedation and flow, and you just go with it for that moment. Because if you haven't made any changes, there probably hasn't been any changes into the blood flow and oxygenation to the brain anyway. We're doing all kinds of other checks and balances. We're doing, you know, blood gases. We're, you know, if we're doing, you know, circle rests, obviously someone's monitoring the head. We're doing different things to also give us little bits of information. And all of those pieces are what we use to be able to put the big picture of, are we taking care of the patient right now? Mm-hmm.
Yeah, I think those are very good points. I think everything you said makes just tremendous sense. And I want my takeaway message. My takeaway message from this is that I do think more information, if it's trusted, is better than less information.
Agreed.
Everything that you think is trusted, you should still look at with somewhat of a skeptical eye, and try and validate whatever you have, especially when it's something that's either really good or not looking good. But it is an early warning. I think cerebral oximetry, albeit I may not be the most confident in it, I think it has a place, should be used more frequently. But I think that the companies have a responsibility to take a more serious approach towards validating and improving their technology so that we can feel a lot more confident in it and do the studies that it takes to create a standard of care so that it is used more often and used more effectively. So at the end of the day, we're here to protect patients' brains. We want them to survive the operation, but also, as I said, go on to have a normal life afterwards. TCD and cerebral oximetry combined may be, in my view, the best way to do it, but I think it's unrealistic in today's environment, especially with anesthesia and their usual territorial aspect. To have all of that on a small landscape for them is going to be very difficult to accomplish. So a lot has to change technologically, but I think over time it very well may. And I think it should be used even more in off-pump, if it's going to be used, than on-pump, because I think off-pump carries with it a much higher risk of cerebral perfusion deficits than does on-pump, frankly.
So, Joe, can I leave a positive final comment on this as well?
Sure.
And I apologize if I repeat anything Tammy just said. I was cutting in and out a little bit on what her last comment. But the good news, as far as this is concerned, as far as I'm concerned, is when I did an entire year at a place, well, more than that, where we used it on every patient, just every routine patient, whatever the number was, whatever our baseline number was, as we were doing the case, and let's say it started to drop, anesthesia got concerned, said, hey, look, we're getting a little bit of a, in the yellow zone. I think it starts to turn yellow first, even in the 40s or 50s.
Yeah.
And so I would make a change. I would increase my CO2 or increase my flow, and I would see it go up 3 points, 5 points. Or if that wasn't enough, I'd give some blood or something, and then it would go up, 5 or 10 points. So the point is that whatever the number is, and then all of a sudden you do something that you know is affecting cerebral perfusion, either increase your CO2, increase your flow, or increase your hemoglobin, and you see that number go up, you know you've done something to positively affect the reading of that device and whatever that device is picking up, right? So for that point, I felt like, and I feel like it is helping us do something. You know what I mean? Despite about where it's aiming and what it's doing, we're showing that what we're doing is bringing those numbers up. And that should have a positive effect on brain perfusion, let's hope.
Okay, fair enough. And Tammy, actually, before you give your final thoughts, Tammy, put that picture up, or the slide. Yes, I just want to show it. Tammy, this was your inaugural Tammy Sparacino's Journal Club. I thought it was fantastic. Great first time. We'll learn a lot. Obviously, this will all evolve and so forth. But this was a great idea on your part, and I thought that this first program was exceptional, and I'm really proud of you and appreciative of your hard work.
Well, thank you, Joe. I think this is something I've always wanted to do, although I didn't ever dream it would be, live broadcast. But I think Journal Club should be something that we're all doing. Not necessarily just reviewing the things that are coming out in the perfusion journals. I don't think you have to be a scholar to be able to do these types of things. I think, there were certainly things in this particular article that were out of my depth. A lot of the statistical information that I couldn't really interpret. However, I was still able to find value in this, and I think more important than even this particular study itself is just the conversations that can bring up the discussions. We started with this, and we went over to talking about proning ECMO, and then using this perhaps in an ECMO and comparing that to pulse oximetry, I think those are all important ways that we can continue to grow and learn, and also it can be pretty fun. So I'm glad to do it, and I appreciate the opportunity and the platform to be able to do that.
Well, thank you. That was all very kind, and I agree with you 100%. I think when perfusion is not what it was in the 1980s or the late 70s when I first started, but the 80s even. We have really evolved as a profession, and our involvement and our stature really within the cardiovascular community and even the intensive care community has grown exponentially from where it was many, many, many years ago. And with that growth and stature comes a tremendous amount of responsibility. So I totally agree with your philosophy that we should all be doing this, because we have to really be able to educate ourselves in order to continue to be considered the experts that we are in the hospital, in our respective departments where we go. So I don't think you can accomplish that if you don't do things like this.
Correct. And on that, just a funny little comment. Speaking with one of our surgeons just yesterday, responding to an emergency, and I had received a notification from the hospital, then also a notification from the surgeon himself. And we were kind of laughing about it, because after the fact, then I also got, notification from various administrator people at the hospital making sure that this had been taken care of. And I said, well, at least they're thorough, they're making sure that we know that, we have something we need to do and get to the hospital. And his comment was, I always make sure anesthesia knows and perfusion knows, because with those two, I can get it done. So I thought that was a great compliment.
That is.
Not to discount the nurses and the scrub techs and the first assistants, because I think his point was, if they're coming in, at least if we can get started with putting the patient to sleep and getting them on bypass, we're going to be good until we can get everything else worked out. And I thought that was a tremendous compliment. So I thought so too, and I do feel that is our reputation here in the Houston metropolitan area, which I appreciate. I know John, you're blowing it up too. You're going everywhere. I want to close out with you, John, but I want to first mention to everybody we're going to be doing 2 of these programs every month, and they're going to alternate in weeks. So the Monday programs are always going to be 9 a.m. to 10:20, and that is Central Standard or Central Daylight Time, depending on what time of the year it is, but Central Time Zone, Central United States Time Zone. So Chicago time, New Orleans time, Houston time, that's the time. And then so the Monday programs, 9 to 10:20. The Thursday programs will start at 5 p.m. and go till to 6 or to 7, depending on the program, how much we decide to add into it, so that people in different time zones can participate in these programs. And that's something that Tammy had discussed with me wanting to do, because we have a lot of European colleagues and also Asiatic colleagues who want to watch these programs and participate. And when we do it always at one particular time, it makes people in Europe, for example, having to stay up until 11 o'clock, 12 o'clock, 1 o'clock in the morning, and that's unreasonable. But these programs live in perpetuity online, so you can either watch it and participate in it live, or you can watch it and also participate by sending emails, questions, or whatever you have in our online format at perfusioneducation.com. So I just wanted to mention that. John, any final thoughts before we say goodbye?
Hey, I thought it was great. I thought it was a really, really good inaugural journal club. I think we take an idea like whatever's on the journal topic, and then we can go and expand around and then come back full circle. And I think people can get a lot out of that, because I think the conversation is where there's just a huge value, and the journal gives a focal point on which to start a good conversation. So I thought it was great. I think you guys did a fabulous job, and I'm in an airport, so I kind of got to get hung up here and get going. But congratulations, Tammy. That was great. Talk to you
Thank
guys
you.
later.
Thanks so much for your participation, John. It's always good to have you on.
And Tammy, thank you very much. John, thank you. Have a safe trip where you're going. And all of you out there, thank you for participating in this inaugural program. And we will look forward to seeing you on Thursday, July 30th, 2020 at 1700 or 5 p.m. Central Time for autologous platelet-rich plasma separation technology used in the same patient receiving 2 complicated aortic surgeries within a short time period. And it's a case report. To follow that will be a M&M, a morbidity and mortality case report talking about various events that occur in different places, not necessarily related to us, although some may be, but what we can learn from those mistakes. So discussing what the issue was, whether it resulted in a major morbidity or mortality, and then what we can learn from that. So that's going to be something we're going to add to the Journal Club to increase the time and increase the number of CEUs that you could get. You got 1.3 for today, and I think the next one, Tammy, is going to be 2.7. So by the end of the year, you could almost have 150 CEUs. I don't think you have to go anywhere else for your CEU needs than right here. And then when we do our live conference, which we are going to do once all this stuff is over, it's going to be incredible. It's going to be a conference like none other. But we got to wait until we get through all of this nonsense. And then all of you folks can come wherever it is we're going to be, and we're going to have one heck of an educational event party. I had to throw the party in there.
Of course.
Of course. What's the whole point, right? Okay,
Right.
Thank you all very much. Have a great day. Tammy, congratulations again. Super job. Thank you very much, and we'll talk later.
Okay. Bye-bye,
Bye-bye,
everyone.
everybody.
Thank you.
The Point of Care program at Huntsville Hospital is approaching its 20-year anniversary. As we began to grow as a hospital and provide more complex services to our community, the need for point of care testing became very clear in our organization. Many of our departments consider the EPOC device to be crucial to their ability to quickly move their patients from entry to the hospital to procedural room. It helps them monitor the patient's status during their procedures and post-procedure, so it's very integrated into our entire continuum of patient care. If you have any patient population where blood management is crucial, then a point of care device is very useful in those types of settings. It can provide a quick result on a very small amount of blood, and that is really important in some of our patient population.
We are starting a new process where we're going to screen our patients on the floor for sepsis. The patient can look and actually feel okay. They will show us signs and symptoms of sepsis. So what we do when they show these signs, we get a lactate level.
Lactic acid is a product of the sepsis cascade. So with sepsis, the inflammatory light switch goes on, the cascade starts churning, and unfortunately, once it starts going, we have to stop it. It will not stop on its own. The faster the lab draw, the faster the lab results, the faster you can act on it.
The process in the lab is what the process is. It just takes a certain amount of time for the instruments to run those tests.
I mean, we're talking 30 minutes even on a stat because that's the process. That's just how long it takes. There's not really anything you can do about that. For every hour you wait to give an antibiotic, the mortality for that patient increases 8%. So now that we have the handheld device, the nurse can get those results within a few minutes, and we know how to treat that patient. If a patient is going into septic shock, we do not have minutes to spare. We have got to get it done quickly. So when you get the little beep from the EPOC that says your results are in, you go with it. You don't even think twice about it. You're like, this is good. This is what I'm going to do for this patient. The next steps are clear.
I think our mortality on the initial floors dropped by almost 50% in the first 3 to 6 months. At this point, we're about hospital-wide. I think we'll be hospital-wide another 2 to 4 months. So this has become a huge program within our system.
Without the EPOC device, it would really be hard for us to get everything done in the timely manner. So it's really helped us to get our program going.
I mean, whether you're a surgeon, whether you're a medicine doctor, whether you're a dermatologist, you want to be able to do things in a timely fashion so that you can be most effective.
This really makes a difference in patient outcomes.
Mixed cannulae, expanding performance standards. High-performance cannulae for direct and femoral cannulation in minimally invasive cardiac surgery. LivaNova's complete range of mixed dedicated products allow easy and reproducible procedures. The portfolio includes the sutureless aortic valve Perceval, Memo 4D for mitral valve repair, the HeartLink system for assisting the perfusionist in applying goal-directed perfusion therapy, and a broad choice of high-performance dedicated cannulae. LivaNova's range of cannulae suit every cannulation technique for minimally invasive cardiac surgery. Venous and arterial femoral cannulation can be performed using the WRAP Venous Cannula and the EasyFlow Duo. For arterial direct and venous femoral cannulation, the EasyFlow aortic cannula and the WRAP are available. For venous femoral access, the LivaNova WRAP cannula features a dual-stage configuration for optimal drainage of the inferior and superior vena cava without interfering with the right atrium. The high-flow dynamics of WRAP improves the capability of drainage with a low pressure drop. An optional Sellinger dilator kit is available to perform percutaneous insertion. The LivaNova EasyFlow Duo cannula is designed for a safe and smooth femoral arterial cannulation. Its conical dispersion tip design allows a more gentle flow in the femoral artery, and its red cap avoids blood backflow during obturator removal. A dilator kit for percutaneous insertion is also included with the cannula. EasyFlow cannulae are designed for safe, reproducible, direct aortic cannulation and include a malleable stylet to aid cannulation insertion, facilitating bloodless introduction into the aortic arch, as well as a special conical dispersion tip for a more gentle flow in the vessel to reduce shear stress.
Like all perfusion professionals today, we are busy and frequently short-staffed. Does taking time off for a conference create a burden for your teammates? Has reimbursement for your continuing education dropped? Have you priced the cost of going to a meeting lately? Registration fees, airfare, transportation and parking, hotel, and meals out? This totals up to having an out-of-pocket expense of over $2,500. And then you hope the content is good. Perfusion Education has heard your concerns. They have a simple and seamless system that works on any platform, computer, tablet, or even your phone. You can chat during the program or even phone in and be live on the air. The content, second to none. Perfusion Education is by perfusionists and for perfusionists. Create a free account and check us out today.